So I'm going to be talking about cyanosis. To give a brief overview, cyanosis is a part of short question in final prof examination, and also it is asked in viva in the practical exams. Okay, so it is more of a practical based question rather than theory. Theory is also asked, but more than theory, viva is more important for cyanosis. Perspective of cyanosis. Cyanosis is very difficult to see in Indians or dark skinned individuals. Okay, it is easier to see in Americans. In Americans and white fair complexion people, even if there's hypoxia, only minimal hypoxia, you can easily see cyanosis. But if you're seeing cyanosis or bluish discoloration of the skin in an Indian, it means that it is too late to do anything. Practically speaking, obviously you have to try to save the patient, but cyanosis is a very grave clinical finding. Okay. Talking about the key points. So the literal meaning of cyanosis is bluish discoloration of the both skin and mucous membranes. Okay. Since Indians the skin is very dark, it is better to observe cyanosis in the mucous membranes inside the oral mucosa. Okay. You can also see cyanosis in the ear lobes. Okay. Definition wise, cyanosis is the presence of reduced hemoglobin more than 4 gram per deciliter. Some textbooks will say 5 gram, but Harrison clearly says 4, so we are going with 4. Okay, so presence of reduced hemoglobin is the major cause. Hemoglobin binds to oxygen. If there is no oxygen, we say it is reduced hemoglobin, and this is why cyanosis occurs. But sometimes there are minor causes of cyanosis like methemoglobinemia and self-hemoglobinemia. So these are also causes of cyanosis, but they are not so common. So if we say a patient has anemia, he has only 3 HB. His HB is only 3. So even in that patient, if even 100% of hemoglobin is reduced, there is no oxygen in 100% hemoglobin, still the amount of reduced hemoglobin will only be 3 gram. Okay, and to see cyanosis we need 4 gram. So what does it mean? It means that the absolute concentration of reduced hemoglobin is more important than the relative amount. Okay, so if there is anemia, it is very so if there is anemia, it is very difficult to see cyanosis. You can see it only if it is very severe, and if you go to the opposite side, if there is polycythemia, you can see very easily cyanosis. Even if it is a very less amount of hypoxia, then also you can see cyanosis. Okay. Okay, so if we are saying that patient has cyanosis, now we have to say whether he has a central cyanosis or he has a peripheral cyanosis. What do you mean by peripheral cyanosis? When we talk about peripheral cyanosis, we mean the peripheries. That means the arm, the hands, the foot. We are talking about the peripheries. There is discoloration in the peripheries. So that is the meaning of peripheral cyanosis. So why does it occur? Peripheral cyanosis will always occur because of some issue in the circulation. Okay. The heart is not pumping enough blood, the blood is not going to the peripheries, then you will see cyanosis in the peripheries. Okay, if you're talking about central cyanosis, okay, that means there is issue in respiration. The patient is not able to breathe properly. That is why cyanosis is occurring everywhere. Okay, so this is a respiratory issue, central cyanosis. How do we check that? By investigation, you use an oximeter. If oximeter is showing low saturation, it means the issue is in respiration. So it is a central cyanosis. If there is peripheral cyanosis, the saturation will be normal. Okay. So what are the causes of central cyanosis? As I said, there has to be a respiratory issue. So COPD, pneumonia, and blood is being shunted. Okay, there is no issue in respiration in these patients. In shunting of blood, in heart disease, if there is shunting of blood from the right side to the left side, there will be cyanosis, and it is central cyanosis, and there is no issue in respiration in this patient. So why there is central cyanosis? The circulation is normal. Peripheries are receiving blood, but the blood that the peripheries are receiving is deoxygenated. So that is why in shunting of blood we will see central cyanosis. And talking about height, yeah, in high altitude, more than 4,000 meters, 4,000 is the number given in Harrison. There is low oxygen in the higher altitude, so you will see an issue in respiration. So central cyanosis will be there. If we talk about peripheral cyanosis, okay, in the cold, Normally also you will see in cold there is sometimes our hands get blue, so that is because of peripheral vasoconstriction in response to cold. Besides that, thrombophlebitis means veins are getting blocked. DVT, very commonly seen DVT. So what is happening in DVT? The vein is getting blocked. Main vein is getting blocked, so the superficial veins get dilated. So veins have deoxygenated blood. Since they are getting dilated, so we will see more of bluish blood in the superficial veins. That is causing peripheral cyanosis. And the most important cause is Raynaud's. In Raynaud's phenomena, you will see a triad of there will be pallor, there will be cyanosis, and there will be rewarming and regain the color in the last stage. If we talk about the sites where to look for cyanosis, peripheral cyanosis is by name itself explanatory, that in the peripheries. Okay, center cyanosis will also occur in the peripheries. Textbook does not mention this. Center cyanosis will also occur in the peripheries, but it will occur most prominently in the oral cavity, in the tongue, in the sublingual mucosa, and mucous membrane of the mouth. Okay, peripheral cyanosis will never be seen in the oral cavity. If you are seeing a discoloration inside the mouth, it means it is a center cyanosis. Okay, so which condition can have both central and peripheral cyanosis? It means there is an issue in circulation, there is issue in respiration. So the answer is cardiogenic shock with pulmonary edema. If there is a heart failure, left ventricle is not pumping blood, the blood will go into the left atrium. From left atrium, it will go into the pulmonary capillary. From pulmonary capillary, it will go into the alveoli. Since there is fluid in the alveoli, there is issue in respiration. Since there is heart failure, there is issue in circulation. So both circulatory issue and respiratory issue. So patient will have both central as well as peripheral cyanosis. That is the answer. Cardiogenic shock with pulmonary edema. Oh, okay, if you have to elaborate the answer more, then you have to talk about approach to cyanosis. How do you approach it? If we see a cyanosis patient, how do we approach that patient? First of all, we have to ask about the time of onset. Does the cyanosis is the cyanosis present since birth? If it is present since birth, most likely the patient will be having a congenital heart disease. So then we have to see if the patient has clubbing. If the patient has clubbing, it means there is an issue in respiration. Respiratory issue is equal to center cyanosis. But not all patients with center cyanosis will have clubbing. So the cyanosis, but not all patients with center cyanosis will have clubbing. So the center cyanosis has to be chronic, not acute. Example of chronic condition is COPD, and acute condition example is pneumonia. So you will not see clubbing in pneumonia. Pneumonia there will be no clubbing. Also, so it has to be a chronic condition, it has to be central cause. Only then you will see clubbing. So if there is peripheral cyanosis, no clubbing will be seen. If you are seeing clubbing, that means that it is a center cyanosis and it is a chronic condition. Then you can check whether you are doing massage or you are warming. What will happen? Circulation will improve. It means if there is improvement on massage or warming, it means the issue was in circulation. So it is a peripheral cyanosis. Blanching versus non-blanching. Okay, cyanosis means there is blood is pooling around. If there is a circulatory issue and the blood is pooled around, if you press it, then the blood will move away. So if it is resolving on blanching, it means it is a true cyanosis. But if there is if you are pressing and still there is discoloration, it means it is a pseudo cyanosis. There is no issue in the blood vessel, issue is in the skin. The skin color has changed. So that is known as pseudo cyanosis. I will explain it later on. What investigation we will do? First of all, you will check with an oximeter if the saturation is low or high. Saturation is low, center cyanosis. Saturation is normal, it is peripheral cyanosis. You can get an ABG done, and for the rare causes, methemoglobin and sulfahemoglobin, you can do a spectroscopy. So these were the basics. Now, what can the examiner ask in the viva? Most common question that can be asked is, what is differential cyanosis? Okay, till now we were talking about cyanosis in the entire body. Sometimes there can be a differential cyanosis, means that there is cyanosis in the legs, but the arms, the hands are normal. Only the legs are blue. That is known as differential cyanosis. And the technical definition is a difference of more than 5% in the legs and arms. So where can we see this? See, this is the aorta, and this is the pulmonary artery. Okay, What is this connection between the aorta and pulmonary artery? This is a patent ductus arteriosus. Aorta, there will be high pressure because it has to pump blood to the entire body. Pulmonary artery is a low pressure zone. Normally, when there is a PDA, the blood will go from the aorta to the pulmonary artery. Okay, so normally when there is a PDA, blood will go from the aorta to the pulmonary artery. So aorta is carrying pure blood. So there won't be any cyanosis in this setting. But later on, when there is so much of blood is going inside here, the pressure inside the pulmonary artery will increase, and it will be more than the pressure in the aorta. So the blood will now reverse its direction. It will go like this from the pulmonary artery to the aorta. What is the pulmonary artery having? It has deoxygenated blood. So now deoxygenated blood is entering aorta, and from the aorta it will now go into the lower limbs. How it is going into the lower limbs and not upper limbs? You can see from this diagram. This is the arch of aorta. Okay, and this here is the PDA, the patent ductus arteriosus. So blood is coming from left ventricle to the aorta, and it is going up here normally. Pure blood, oxygenated blood is going up normally to the upper limbs. Now the supply to the lower limbs is coming from here, and this is the PDA. PDA is carrying blood from the impure blood from the pulmonary artery. It is going like this, and from here it is going down to the lower limbs. So the lower limbs will have blue blood. Blue blood means it will have bluish discoloration, and the upper limbs will be having oxygenated blood. So this is PDA with pulmonary hypertension. PDA with pulmonary hypertension, there will be differential cyanosis. Then the question can come, what is reverse of differential cyanosis? Reverse differential cyanosis means the opposite. The arms are blue, legs are normal. So where you can see, this is seen in TGA. TGA with PDA with pulmonary hypertension. TGA with PDA with preductal coarctation. Now let's understand, it's not very difficult to see. So this is the right ventricle. This is left ventricle. Normally, what should be there? There should be a pulmonary artery, but now here there is aorta. This is aorta, and here this is the pulmonary artery. Okay. Since aorta has to pump blood to the body, aorta pressure will be higher. Pulmonary artery here pressure will be low. So, okay, now see, this is right ventricle. This is aorta. Right ventricle to aorta to the whole body, returning to the right ventricle, aorta to the whole body. This is left ventricle, pulmonary artery, lungs, getting oxygenated pure blood, going to back to the left ventricle, and a loop is formed. So this is not sustainable with life. Such a circulation, this is right ventricle, only impure blood, that is deoxygenated blood, is going to the body. So how this can survive? So there has to be some connection between the two, only then the child will survive. So if we see, this is, what is this? PDA. So if the PDA is patent, only then there can be some survival. Okay, so now there is a PDA. Aorta has a higher pressure. Blood will go from the aorta to this side. Okay, now we are not interested in this. Now we will see what happens if there is pulmonary hypertension. Yani yahan pe in the pulmonary artery there is more pressure. Now blood will go from the pulmonary artery back to the aorta. Okay, so what is going? Pure blood, oxygenated blood is going from the pulmonary artery to the aorta when there is pulmonary hypertension in a patient with TGA with PDA. You can see in this diagram, what is this? This is the arch of aorta. Okay, what is this blue color? Blue color is the deoxygenated blood which is coming from the right ventricle into the aorta and now going to the upper limbs. When we come down here, what is this? This thing is the PDA. Okay, so from the left ventricle, the pure blood is going from the PDA because there is a pulmonary hypertension. It will go from the PDA into the lower limbs. So the lower limbs are getting oxygenated blood, but the upper limbs are getting deoxygenated blood. So there are blue arms and normal legs. So this is a similar concept. If you see TGA with PDA with the preductal coarctation. What does the preductal coarctation mean? This is the PDA. This is duct, patent ductus arteriosus. So this duct, before this, there is a narrowing here. Okay, so there is a narrowing here. Okay, since it has become narrow here, pressure is very high before this narrowing, pressure is very low after this narrowing. So in this case, we do not need pulmonary hypertension. Blood will automatically come from the left ventricle to the low pressure area and go down. So in these two patients there will be reverse differential cyanosis. That is all about cyanosis. Now we can solve some MCQs. So central and peripheral cyanosis both are seen in shock. There will be peripheral cyanosis. CHF, heart failure, circulatory issue, peripheral cyanosis. Peripheral vascular disease, circulatory issue, peripheral cyanosis. Cardiogenic shock, circulation, pulmonary edema, respiration. In this patient, there will be both central and peripheral cyanosis. In peripheral cyanosis of the extremities, the arterial blood is okay. So if there is peripheral cyanosis of the extremities, what is happening? Example I am giving you of DVT. DVT, the blood supply to the artery is normal. What is happening is the vein is blocked. When the vein is blocked, there is more time for oxygen to leave the hemoglobin and enter tissues. So arterial blood saturation will be normal. In the venous blood, there is increase in the deoxygenated blood. Artery is normal. Okay. Differential cyanosis is a feature of, just now we talked about differential cyanosis. It will be seen in PDA. PDA, not only PDA, PDA with pulmonary hypertension. Okay. So cyanosis is usually most marked in. Okay. This is actually a line pickup from Harrison. Harrison does not say cyanosis is seen maximum in nail beds, maximum in ears. It is just written that it is most seen in all three: nail beds, ears, and malar eminences. So there is no one answer. Answer is all of the above. Okay, cyanosis can be observed in all except if there is polycythemia, you will see cyanosis very easily. If there is methemoglobin, cyanosis will be present. Self-hemoglobin, it will be present. What about carboxyhemoglobin? In carboxyhemoglobin, there is cherry pink discoloration, not cyanosis. Okay. In carboxyhemoglobin, there is cherry pink discoloration, not cyanosis. Okay. Just a few 3-4 points. Methemoglobinemia, self-hemoglobinemia are very minor causes of cyanosis. What is happening in methemoglobin? Patient is taking a drug. Usually, drug is nitrate. When patient takes the drug, the iron gets oxidized. Okay. Iron is now oxidized. Once iron is oxidized, now it cannot accept any more oxygen. So oxygen cannot bind to hemoglobin. Oxygen cannot bind to hemoglobin. Oxygen is entering normally from the lungs to the blood. Entry is normal, but when it enters the blood, it cannot bind to hemoglobin because hemoglobin is already oxidized. So oxygen transfer to blood is normal. PA2, so PA2 will be normal. If you do an ABG and you see the PA2 is normal. But the hemoglobin is not saturated with but the hemoglobin is not saturated with oxygen. Hemoglobin is not saturated with oxygen. It does not have oxygen molecule attached to it. So saturation, if you check with the pulse oximeter, it will be low. When do you suspect this? If the patient has cyanosis, it is a central cyanosis, you are thinking he has a respiratory issue, but you are giving oxygen to that patient, but still there is no improvement, you can think that the patient is having methemoglobin due to some drug. That drug is mostly it's a nitrate. Okay. Similarly, there is something known as self-hemoglobin. Okay. When a patient takes a sulfur-containing drug, the sulfur in that drug will attach to the hemoglobin. When it attaches to the hemoglobin, now oxygen cannot bind. Very similar to methemoglobin. So just like that, in that case, oxygen transfer to blood is normal. So PaO2 is normal in ABG. If you do an ABG, the PaO2 will be normal, but the SaO2 is low. Lastly, there is something known as pseudocyanosis. The blood vessel is normal, only the skin is discolored. That is seen with amidron. You may have heard of this earlier also in pharmacology. Amidron causes blue discoloration of skin. So that is amidron. Another cause is chrysiasis. What is chrysiasis? In historical importance, what is chrysiasis? It has a historical importance. Earlier in RA, when we were giving gold to the patients, that time in very few patients this used to happen. Blue discoloration of skin used to happen. That was called as chrysiasis. How do you distinguish? Since the issue is in the skin, not the blood, so if you blanch it, the color will remain the same. If it is a true cyanosis, it will blanch. But it is a pseudocyanosis, so this will not blanch.